Welcome, and thank you for joining us today. My name is Ellen Wilson, and I'll be the moderator for this media briefing, which is hosted by the Johns Hopkins Malaria Research Institute at the Johns Hopkins Bloomberg School of Public Health. Today's speakers will discuss the rollout of new malaria vaccines, the global state of malaria, including recent trends and cases, and the potential impact of shifting global health funding. I'd like to briefly introduce our speakers. Jane Carlton is director of the Johns Hopkins Malaria Research Institute at the Johns Hopkins Bloomberg School of Public Health. She is also a Bloomberg Distinguished Professor in the Department of Molecular Microbiology and Immunology at the school and in the Department of Biomedical Engineering at the Johns Hopkins Whiting School of Engineering. William Moss is a professor in the Departments of Epidemiology and International Health at the Johns Hopkins Bloomberg School of Public Health. He is Deputy Director of the Johns Hopkins Malaria Research Institute and Executive Director at the school's International Vaccine Access Center. We will have time for questions during this discussion. We hope to take some that have been submitted in advance of the briefing and some from the Zoom chat. If you have a question, please enter it in the Zoom chat addressed to panelists and hosts. Please enter your name, media outlet in question. We hope to cover as many as possible. Please note that participants are welcome to use images, video, or quotes directly from the briefing, and that the content is for immediate release. Participants will be muted during this briefing, and it will be recorded. Let's go ahead and start. Professor Carlton, what is malaria, and what is the current global status of the disease?
Thank you, Ellen, and thank you to the participants for joining us today. Malaria is one of the big three global infectious diseases recognized by global health organizations, including the World Health Organization. It's one of the deadliest and the most burdensome in human history. It's a disease of historical significance and an enormous ongoing global crisis in lower-income countries. Estimates from the World Health Organization last year gave 280 million malaria cases and 600,000 deaths, primarily in children under the age of 5. Malaria is endemic in 80 countries. Half of those are found in the African continent, and 5 countries in particular, Nigeria, the Democratic Republic of Congo, Uganda, Ethiopia, and Mozambique, accounted for half of all cases in 2024. Malaria is caused by a parasite that infects human blood. It's transmitted through the bite of infected mosquitoes. There are several different species of malaria parasite and at least 40 different species of mosquito that can transmit them. However, malaria is a treatable disease if it's caught early enough, but there are key threats to progress to eliminate the disease. Some of these include anti-malarial drug resistance. The parasite has become resistant to artemisinin, which is the frontline anti-malarial drug in current use. And this resistance has now spread in several African countries. Mosquito resistance to the insecticide used on bed nets is now also widespread. And diagnostic tests for malaria are failing due to the spread of mutant malaria parasite strains that cannot be detected by them. The spread of invasive mosquito species that thrives in urban settings and is more resilient to warmer temperatures is also of concern. And finally, the financial challenges that have been occurring over the past year, the reprioritization and decreased global health funding, including downsizing of USAID's President's Malaria Initiative. Already we see shifting patterns of malaria. 2.5 times as many cases in Namibia were reported in the first 3 months of 2026 than the whole of 2024. In Nigeria, more than 24 million malaria cases occurred in the 9 months of 2025, and this was greater than the previous 12-month totals. And in Mozambique, malaria cases more than quadrupled in 2026 compared to the same period in 2025. There is cause for some limited optimism. There are 47 countries and 1 territory that are malaria-free, including most recently Egypt and Timor-Leste in 2025, and other countries are on track to eliminate the disease in the coming years. We have new dual active ingredient bed nets, which are being deployed. And here at the Johns Hopkins Malaria Research Institute, malaria researchers are pushing forward with others to develop new antimalarial drugs, novel methods for controlling mosquitoes, and new vaccine candidates. World Malaria Day, which is held each year on April 25th, is our call to arms for global action, for investment and sustained commitment to fight a deadly disease that kills hundreds of thousands of children in Africa each year.
Thank you, Professor Carlton. Now a question for Professor Moss. We have been waiting a long time for a malaria vaccine. What malaria vaccines are currently available, and how did we get here?
Yes, a safe and effective malaria vaccine has been a holy grail for malaria control for many decades, and our current malaria vaccines are good and can prevent tens of thousands of deaths each year. But there is a lot of room for improvement, and we must continue to invest in the research needed to develop more effective vaccines while ensuring children have access to our current vaccines. So the two currently approved malaria vaccines, the RTSS and the R21, are really based upon decades of research. Both vaccines target the same protein on the surface of the sporozoite. That's the form of the parasite that is injected by the female Anopheles mosquito. This protein, called the circumsporozoite protein, induces a protective immune response. And both vaccines also have what we call an adjuvant to further stimulate this immune response. Early experimental work in the 1960s and 1970s shows that it was possible to induce a protective immune response using irradiated sporozoites. The RTSS vaccine was first developed in 1987 by Smith, Kline, and French, which is now GSK, and the Walter Reed Army Institute of Research, but was not recommended for use by the World Health Organization until 2021. So a 34 years from development to approval. The reasons for this long timeline are complex and multiple, and are due to the biological challenges of developing a malaria vaccine, having sufficient funding to move the vaccine through the clinical trial pipeline, the long duration of some of these clinical trials, and then the need, as determined by the World Health Organization, for a malaria vaccine implementation program to show in 3 countries that this vaccine was safe and could be implemented programmatically. The final trial results were published in 2015, and vaccine efficacy against clinical disease and severe disease varied by the age of vaccination, the number of doses, the timing of doses in relation to the transmission season, and the time since vaccination, because there is waning immunity. When 4 doses were administered to children 5 to 17 months of age, the risk of malaria was reduced by 39% and the risk of severe malaria by 31%. Although this is lower vaccine efficacy than many of our other childhood diseases, because of the huge burden of disease due to malaria in high transmission settings, this results in a significant public health benefit. And Gavi has forecasted that by immunizing 50 million children, which is their goal, they could save more than 170,000 lives between 2026 and 2030. The R21 vaccine was created at the Jenner Institute at the University of Oxford in 2012 with the hope of improving vaccine effectiveness. It is similar to the RTSS vaccine, but presents more of this circumsporozoite protein to the immune system. Vaccine efficacy was higher in a phase 3 trial, and this vaccine was recommended for use by the World Health Organization in 2023. The big push now is to get these vaccines to children. As the old quip goes, vaccines don't save lives, vaccinations save lives, meaning that we have to get these vaccines that we've developed into the children who need them most. 25 countries in sub-Saharan Africa have introduced a malaria vaccine nationally or subnationally with support from Gavi, the Vaccine Alliance.
Thank you so much, Professor Moss. Now we will take additional questions, and a reminder, if you have a question, please enter it in the Zoom chat with your name, media outlet, question, and to whom you'd like to address your question. The first question is from Ruben Lukumbuka with Radio France International for Professor Moss. What is the status of malaria in those countries which didn't receive the new malaria vaccines?
Yeah, so many of the high burden countries have already introduced the one of these malaria vaccines. Most have introduced it what we call subnationally, meaning that they're targeting those districts or areas of their country where they have moderate to high transmission. But there still are a few countries that have not yet, with a high burden of malaria, that have not yet introduced a malaria vaccine. Probably the three best examples right now are Angola, Tanzania, and Madagascar. We know that Angola has plans to introduce a vaccine. And what we hope is that these countries with high burden of vaccine that have not yet, with high burden of malaria that have not yet introduced the vaccine, will use some of their Gavi funding to introduce the vaccine.
Great, thank you. And a question from Caroline Mattei with Radio France International, again for you, Professor Moss. Do we foresee many African countries rolling out the vaccine, given the change in funding models across the globe?
Yeah, so I mean, I hope we'll continue to see an expansion of the use of malaria vaccines. Malaria vaccines are funded largely in these countries through Gavi, the Vaccine Alliance. Gavi has changed their kind of funding structure and their application structure as we transitioned from Gavi 5.0 to Gavi 6.0 earlier this year. This funding structure it includes countries submitting a single application for a 5-year period, and the funding falling into two buckets: guaranteed funding and discretionary funding. The guaranteed funding covers a number of really essential childhood vaccines, like vaccines for measles and rubella. Malaria vaccines fall in this discretionary bucket where there are a number of other vaccines, including cholera and yellow fever vaccines. So it's really going to be up to the countries, and this is part of Gavi's goal is to really make have countries have the freedom to kind of make their decisions. And so countries will have to decide how they want to use this discretionary funding bucket and how much of those funds to allocate to malaria vaccines. And then the bigger picture is that funding and support for Gavi was lower than what we had hoped for. So that funding, those funding envelopes are a little less than what we expected. But it will really come down to country level decisions about prioritizing malaria vaccines using this discretionary funding from Gavi to reach those children most in need within their countries.
Great, thank you. A question for you, Professor Carlton from Apollonia Adeyemi with New Telegraph in Nigeria. What are the new tools to tackle malaria, considering it's been with us in Africa for too long?
Yes, thank you. There are several new tools which are being rolled out in the African continent. In particular, deployment of new generation dual active ingredient bed nets. So these are very important in that they combine a pyrethroid insecticide with a second compound that inhibits the enzymes that the mosquito uses to detoxify that insecticide. So they've been very successful in trials, and now they're recommended for use by the World Health Organization. As we heard as well, wider rollout of malaria vaccines but then also there's been expanded access to seasonal malaria chemoprevention, or SMC. And this involves administering monthly doses of anti-malarial drugs during the peak malaria season to children under the age of 5. Those are the most vulnerable to severe malaria. And there are about 20 countries in Africa now using SMC. Kenya was the most recent country, in fact, to start using it. And in addition, of course, new research tools are being developed. Here at the Johns Hopkins Malaria Research Institute, we are engineering mosquitoes that are resistant to malaria parasite infection. We're repurposing known drugs into new anti-malarial drugs, and then identifying the scents that people give off to develop baits and attractants or repellents for mosquitoes. So there's much new research that is going on to develop new tools that can be then deployed in African countries.
Great, thank you so much. For you, Professor Moss, a question from Kate Lay with The Guardian. How effective do you think multilateral organizations such as the Global Fund are being in tackling the changing threat pattern for malaria?
Yes, I think these larger multilateral organizations are trying to adapt quickly to the changing funding landscape, and particularly the withdrawal of the U.S. government funding that has supported many of these programs. Um, this is still a very dynamic situation, but we are concerned about at least temporary breaks in the ability of countries to deploy some of these key malaria control interventions. And the problem with malaria, particularly in high transmission settings, is that the transmission is so intense, the burden is so high that even temporary disruptions in some of the commodities like rapid diagnostic tests or artemisinin and combination therapy or bed net distributions can result in a high number of severe malaria cases, hospitalizations, and deaths. So I think these multilateral organizations are trying to adapt and be able to provide countries with the support they need to avoid these kind of disruptions. But the U.S. government funding was so critical to many of these programs through the highly successful President's Malaria Initiative that I am concerned that we're going to see some disruptions and an inability of countries to kind of maintain key aspects of their program.
Great, thank you. Again, for you, Professor Moss, freelance Caitlin Sullivan, are we already seeing the parasites evade the vaccines we have?
Yeah, this is a really important question. And one of the things we know about the Plasmodium falciparum parasite, it is a very wily foe. We've seen obviously the emergence of drug resistance. We've seen the emergence of this parasite to evade some of our common diagnostic tests. And we are concerned that there may be evolutionary pressure on the parasite to evade vaccine responses. We haven't seen strong evidence of this yet, but this parasite has such an ability to kind of basically have genetic diversity such that it may reduce some of the effectiveness of the vaccines. And I'll just say this is one reason why we need to continue to invest in better vaccines and vaccines that target multiple stages of the parasite life cycle to reduce its ability to evolve away from the protective immune responses that these vaccines confer.
Great, thank you. A question for you, Professor Moss. A question from Tori Whittaker, Martinox with Infectious Control Today. Will the vaccines you discussed be available to people who will be traveling to malaria endemic countries?
Yes, these vaccines are not the ideal vaccines for travelers. These vaccines really are designed for children living in endemic areas. They require 4 doses really to see the protective immune response. It's a 3-dose primary series, and then 1 year later, a booster dose. There is work on developing vaccines for for travelers. They're not yet available yet, but this has been a focus of research for many years, and also to protect our military. And this is one of the big drivers of malaria vaccine development, and that's in fact the early motivation for the RTSS vaccine development, to protect military who are personnel who are deployed to a malaria endemic area. So I think in the coming years we will see better vaccines, and perhaps even monoclonal antibodies that could be used to protect travelers. Of course, we do have drugs, chemoprophylaxis that's highly effective in preventing malaria in travelers as long as we take the doses.
Great, thank you. A question for you, Professor Carlton. From Michael Guarisa with Health Times in Zimbabwe, you indicated that pesticide-resistant mosquitoes are spreading and increasingly encroaching into urban settings. From your findings, is Zimbabwe also experiencing this shift, particularly in terms of resistant mosquito populations, or changing malaria patterns? What is the current status based on available evidence?
I think it's still early days for us to be tracking this invasive species of mosquito. It's called Anopheles stevensii, and from about 10 years ago, studies started to reveal that the mosquito was coming over from parts of Southeast Asia, in particular into countries in the Horn of Africa. And so we know that Anopheles stevensii is able to sustain and breed in much hotter temperatures. And so it's ideally grows in urban areas. And so because of this, we're particularly worried that it may be spreading out of the Horn of Africa into other countries. As I say, it's too early at this stage to be able to determine the exact spread of the invasive mosquito, but this is work that is ongoing at the moment.
I can add a little bit here too, because under the International Centers of Excellence for Malaria Research, we now largely conduct malaria research in Zambia, but also conducted malaria research in Zimbabwe and Mutasa district on the border with Mozambique. And there's certainly insecticide resistance in Zimbabwe, and high levels of pyrethroid resistance. And so the Zimbabwe Ministry of Health and Malaria Control Program has tried to use different insecticides to address this problem. We have not identified yet, although our search has been limited, as in Anopheles stevensii in Zambia, and I don't think it's spread down as far as Zimbabwe.
Great, thank you. A question for you, Professor Carlton. We're seeing both progress and concerning increases in malaria cases in some countries, as you mentioned. What are the key drivers behind these divergent trends?
Yes, thank you. So in particular, a key driver are humanitarian emergencies. And these are emergencies caused by armed conflict and natural disasters that really heighten malaria risk in many countries. These can displace populations and alter ecological habitats and put a real strain on the healthcare systems in those countries too. In fact, in 2023, there was an estimated 80 million people displaced in malaria endemic countries, and 70% of those were thought to be uprooted by conflict or natural disasters. And a recent example, too, is also Ethiopia, where there's been a surge in malaria cases over the past several years. And this has been associated with the disruption of basic health services and malaria control and prevention measures, in particular in conflict affected areas. So that's one key driver. A second key driver is climate change. As temperatures rise, competent mosquitoes can transmit malaria, and they move into previously malaria-free regions. Similarly, changing weather patterns and extreme weather, such as floods, increase mosquito breeding grounds. This has recently been identified and seen in Gaza province in Mozambique, where malaria and also cholera have surged, according to health authorities there.
Great, thank you. Professor Carlton, you've worked extensively on genomics and parasite tracking. How are new tools like genomic surveillance helping researchers and policymakers stay ahead of malaria spread or resurgence?
So decoding of the genome or the genetic blueprint of the malaria parasite occurred more than 25 years ago, and it was a major milestone in the malaria research community. It led to the development of what are called genetic markers or tags in the genome that can be used to track the spread of malaria parasites through countries and over borders. And this genomic surveillance, as we call it, is being used most recently to track the spread of new drug-resistant strains. So, for example, while previous antimalarial drug resistance was found to spread from Southeast Asian countries into Africa, our current evidence collected by researchers using genomic epidemiology indicates resistance to the frontline antimalarial drug artemisinin has instead emerged independently within African countries. And so researchers, for example, in Uganda, are working with policymakers on the ground to develop these real-time epidemiology studies to discuss then the implications of this type of drug-resistant spread and the possible solutions.
And Professor Moss, what about trackers? How are they helping researchers and policymakers stay ahead of malaria spread and or resurgence?
Yes, there are a number of different kind of near real-time trackers that are being used to monitor the disease burden. We at the International Vaccine Access Center have a website called ViewHub, where for many years we've been tracking new vaccine introductions for largely for routine childhood immunizations. And we recently implemented a malaria vaccine tracker. So people can go to that website, viewhub.org, and look at those various modules. We also have information on disease burden, the dosing schedules, the type of vaccine that is being used in a particular country, RTSS or R21, and follow new vaccine introductions going forward. And I hope we'll see more, as I said earlier, particularly in those high burden countries that have not yet introduced a malaria vaccine.
Great, thank you. And our last question, with uncertainty around U.S. and global health funding, what are the most immediate risks to malaria control programs?
Yes, I would say the most immediate risk, and I alluded to this earlier, is with the purchasing and distribution of what we call commodities. And this includes rapid diagnostic tests, anti-malarial drugs, insecticide-treated bed nets, insecticides for indoor residual spraying, another type of vector control. So disruptions to this flow of anti-malarial drugs and diagnostic tests and preventive measures is, I think, the biggest urgent threat. And because of the high burden of disease, particularly in children younger than 5 years of age, we will very quickly see increases in the number of cases, severe malaria, hospitalizations, and deaths due to malaria. There's also been a tremendous loss of expertise in the malaria control programs and the technical support that these funds help to provide.
Great. Thank you both for answering all the questions. We will now take a few minutes to share brief closing remarks. Professor Carlton, please go ahead.
Thank you, Ellen. We are seeing early indications of how shifting priorities and reductions in global funding may influence malaria control and surveillance, leading to an increase in cases and deaths. But even in the face of new challenges to global health initiatives, the malaria research community continues its work in and with endemic countries to combat the scourge of malaria.
Thank you, Professor Carlton. Professor Moss, please go ahead.
Yes. wish to point out that malaria vaccines are just one tool in our toolbox to reduce the burden of malaria among children in sub-Saharan Africa. They can't do it alone. And so this reduced support for malaria control programs further threatens our progress and may even overwhelm the added benefits of malaria vaccines. We are far from having the ideal malaria vaccine, and we must continue to invest in research to further improve the effectiveness of these vaccines and bring to licensure vaccines that prevent the transmission of malaria parasites.
Thank you to Professors Carlton and Moss for your insightful answers. We will email the links to the resources mentioned today and share it in the chat. With that, I'd like to say thank you again to everyone for joining us today. A link to this recording and an unofficial transcript will be provided later today.